afternoon, everyone. I'm Linda Dixon from the Lexington Veterans Association, and I'm happy to welcome you to a presentation on pandemic, on the front lines of the life and death battle with COVID-19. We extend a warm welcome to our fellow veterans who may be viewing this program from the Edith Norse Rogers Memorial Veterans Hospital in Bedford, Massachusetts. It's my pleasure to introduce our speaker, Sarah Carnes. Sarah Carnes joined the Bedford VA healthcare system in 2017 as clinical librarian. When COVID-19 struck the facility in February 2020, Sarah was detailed as acting emergency manager, and her duties were to oversee the infection control, testing, and outbreak management. Sarah's education, military experience, and background in healthcare operations, public health disaster planning, and emergency management training made her the ideal match for this job. A graduate of the University of Virginia, Sarah was commissioned in the U.S. Army Medical Corps through ROTC in 1993, and she served 8 years, mostly in field units, coordinating medical services and evacuation for soldiers in the U.S. and Europe. She managed the command center in response to Al-Qaeda's bombing of the USS Cole in Yemen in October 2000. She later earned a master's degree in library and information science with a focus on disaster information and healthcare. Sarah will describe her duties as acting emergency manager from February to July 2020, sharing the round-the-clock effort to care for the veterans and keep them safe. Volunteers are a critical part of this team effort, bringing brief moments of companionship and comfort to veterans who are lonely and isolated. In December 2020, Sarah assumed her current position of acting supervisory health system specialist for the Chief of Staff. And so, would you please welcome Sarah Carnes. Sarah.
Hi, Linda. Thank you so much for having me here today. It is such an honor to be able to speak to the group again. It has been my pleasure to work with a number of the members of the Lexington Veterans Association for the last few years, since they have been volunteers in my library. And I have had the privilege also of attending several of your meetings and watching many of your recordings. I also want to thank everybody who helped put together this presentation, to include Jim Ramsey and Christine and Terry. It has been so much fun working with all of you, and you're so professional. I really appreciate that. So Christine's going to help me out by sharing my slides today, and I am really happy for the opportunity to talk about what the members of the Bedford VA accomplished over the last year. While the title of this presentation is Pandemic on the Front Lines of the Life or Death Battle with COVID-19, I want to make it clear that I don't consider myself as having been on the absolute front lines. Those people really were our healthcare workers, our nurses, our doctors, our nursing assistants, our environmental management staff, our engineering staff, and so many others who were physically present with our patients on the units day in and day out. And so I'd like to give you a little bit of a background on myself, but really highlight the amazing accomplishments that they had over the last year and where we're moving forward now in 2021. Next slide, please. So I want to clarify again, or emphasize again, that this is a summary of my experiences as the acting emergency manager at VA Bedford for the time period of March through July. It seems like a much longer time frame, or it did during that time frame. But now looking back, it's almost shocking to see that that's just a handful of months. This was really the first wave of our COVID response here. And the information that I'm presenting is publicly available. I'm using the information published by our public affairs officer to the press and to the public in our operational and stakeholder updates. But I want to make sure you also know that I'm not representing a position of the Department of Veterans Affairs. I am a federal employee. I work at VA Bedford, but I'm not speaking for them. I'm just presenting information and some of my experiences. Next slide, please. So some of you know me as the librarian at VA Bedford, so it might come as a surprise that I was involved in emergency management. And I can tell you it certainly was for a number of our staff. They were really curious why all of a sudden we had a number of different people in different jobs, in particular a librarian suddenly managing or working together with everybody in emergency management. But my background actually really supported that, believe it or not. My focus has always been in healthcare in many respects, usually in medical services at the EMS level or the first responder level. I managed ambulance platoons and medical companies, and commanded a medical company in Albania that was based out of Germany. And then I worked in a hospital setting at Landstuhl Regional Medical Center. And as Linda mentioned, I was responsible for the command center there to manage the sailors coming back from Yemen or being evacuated from Yemen after the attack on the USS Cole. And that really felt like a true culmination of all my experiences collaborating with different services and people of different professions to provide care, but in a much more intense way. And I felt really privileged to have the chance to be part of that. And it was something that made me realize how much I enjoyed being part of a team responding during a crisis. We'd done many, of course, during my time in the Army, but this was of such a larger scale and scope that it really made us feel like we were part of something useful. And I really was lucky enough to be able to carry that on when I left the service after 8 years. I went to Northern New Jersey and worked at Atlantic Health System. Being that it was post 9/11, there was a lot of impetus to prepare both in healthcare and throughout the community. And my work was at a hospital system, but in collaboration with public health and hospital associations, as well as businesses, to ensure that we were ready to respond to mass casualties and provide mass vaccinations. We also did a lot of planning for SARS, which was emerging at that time, and we were concerned about the threat of smallpox. And so emerging infectious diseases, both through natural circumstances as well as bioterrorism, were something that we really worked hard on. And again, like I said, we did planning at the local level, but all of that had to be dovetailed and collaborated in collaboration with people at all different levels and organizations at all different levels to ensure that we had a true system of response. And that was building on that experience in the Army, and made me realize again, how amazing people are who are in the emergency response realm and in the healthcare realm. And I transitioned then to become an adjunct instructor at the National Emergency Response and Rescue Training Center. We conducted training and planning at the military, federal, state, and local level. For instance, I helped out the state of Maryland with its smallpox plan and conducted training with the Air Force in Japan, with the state of Hawaii, with organizations throughout Texas, with organizations in New Jersey and New York, like the Port Authority. My focus was always on healthcare, but I was there with a team of people who covered other areas, and we provided a really comprehensive package of planning and training and evaluation. And I, at the same time, became a consultant with a smaller company that was working with businesses like Pfizer. So we went to Pfizer and we helped them with their plans for, again, emerging infectious diseases, bioterrorism, other types of terrorism, and evacuation, because they had a lot of concerns about how they might be able to handle large building evacuation within an urban setting. Next slide, please. So that prompted me to follow on with a master's in library and information science. I initially actually was going to go for a master's in emergency management at John Jay and was in that program, but I was married to someone in the military and traveling around a lot. And so I really wanted to make sure that I had the opportunity to still study about something in disasters, but in a program that I really, really enjoyed and gave me some flexibility because of my the personal circumstances I had with being married to someone in the military. So I ended up following a couple of my friends' footsteps and going to the University of Washington, which could be done remotely. And my focus was on medical librarianship or healthcare librarianship, as well as disaster information, something I didn't realize was available, and it's rather niche, of course, but it was something that I really appreciated. So I got a chance to study with some of the best instructors. It was a 3-year program with 73 credit hours. Very intense program, and part of that included a directed field work, which I conducted with the Massachusetts Public Library Outreach, as well as the National Library of Medicine Disaster Information Management Research Center and the National Network of Libraries of Medicine. And in that, I worked with a lot of librarians and emergency management throughout the state of Massachusetts to help prepare libraries to reach out to communities and support them during disasters, because we learned over the last several years that libraries played a huge role in supporting the community during and after a disaster, when people needed access to information, to people who had resources and reference capabilities, such as the librarians themselves, or needing a shelter location, but also really a place that felt like a safe haven. So that was a really great experience for me, being able to combine those two backgrounds and interests of mine. And I ended up putting together a website, and also then presented the resources through a variety of meetings and webinars, to include the webinar I had with the National Network of Libraries of Medicine that was at the national level. And it was nice to see that people then were adopting some of these tools for themselves at their libraries, to be able to share with their patrons how they could get access to information through applications, through paper copies, or in other manners, such as websites, to prepare for a disaster and also to manage one. Next slide, please. And the other thing that I did when I was at University of Washington was get very involved in research. I was a senior researcher and a senior research team manager, and we conducted research on 2 events in particular. One was the Oso mudslide that hit Washington State in 2014. A huge mudslide came down right in between 2 different towns, which caused a lot of challenges for communication and response. So we did a lot of studying on how people managed information sharing, as well as action upon that information. We also did a huge study of the Cascadia Rising federal exercise, and I'm not sure if you all are familiar with that, but there's a big concern about water rising on the coastlines. Many of us are familiar with that for here in Cape Cod and Massachusetts, but they were concerned about it hitting a very large region in the Pacific Northwest. And so we were conducting a federal exercise and then studying it, so we could see how the different organizations at state, local, federal level could work together across town, county, and state lines. We got some really great information from that. So we actually published 2 papers from the Oso landslide or Oso mudslide disaster study. One was presented at the Hawaii International System Sciences Conference, and the other was presented in France at ISCRAM. And, that was an opportunity for us to share our lessons learned and to see from many others that they had similar challenges with communication. Next slide, please. So this slide's a little bit jumbled, but I guess sort of the effect tells you. I've done quite a bit of presentations and publications related to disaster information and disaster preparedness. These are just some of them, but they range from the ones I conducted with the hospital associations and health officers, as well as the police in New Jersey, to those that I've conducted in Massachusetts since I got my master's program. Okay, next slide, please. And when I finished my program at University of Washington, I originally thought that I was going to be working with the National Libraries of Medicine at their Disaster Information Management Research Center, but then they were not able to hire, and I was lucky enough to learn that VA Bedford was hiring a clinical librarian, which is really where my heart is, because I really love supporting healthcare as close as possible, just like I did in the Army. And I've been extremely lucky to be a member of the VA Bedford healthcare system since 2017, managing services not just for clinicians and administrators and researchers, where I provide them information or assist them with their research or their education of trainees, but I've also been able to really grow the library services that Jim Ramsey put together, obviously one of LVA's most prominent members. I met him, I saw what he was doing with our veterans here as a volunteer, and I realized that he had cracked the nut on how to make sure that he was providing good services to veterans. The only challenge is that we didn't have 30 Jim Ramseys to go around. So we built our program really on what he had established, and drew in more volunteers, many of whom are members of LVA, like Aaron and Frank and Dick and Tom, who are probably maybe watching today or will be soon. And we built a really beautiful program where we visit all the veterans at the units and deliver them materials. Those materials could be books or magazines or movies or music, but also we deliver them friendship and respect. And it's been just an incredible experience also working with the staff to provide programs and support to our veterans as a team. The other thing that I also established here was the literature alerts, the ones that you see listed there. The VA Library Network is the largest network of medical librarians in the world, and the VA has put a lot of money into ensuring that it has the best, most current evidence-based care for our veterans. One of the tools that we use to ensure that our staff are up to date on information are these literature alerts. The ones that I covered included opioid epidemic and geriatric psychiatry. These were concerns for our staff here, and I learned that they were definitely concerns for clinicians and researchers at other VAs and elsewhere. And then starting in January 2020, I approached our director of the VA Library Network, and I asked her if she would be interested in me conducting one on the coronavirus because it was emerging. And she said yes, and was very supportive of it. So starting a year ago, I started delivering that out to staff both within the VA and actually providers and researchers outside of the VA as well. So to well over 800 people each week. Next slide, please. So VA Bedford has been doing a lot of preparation for emergency management as a requirement. That's something that all healthcare organizations have to do. And the VA was keeping tabs on what was going on with COVID from the very beginning. And so VA Central Office required all sites to conduct tabletop exercises and to review their plans and ensure that they could make some revisions as early as possible in preparation for what they anticipated would be a threat to not just the VA, but for veterans everywhere and for communities everywhere. And the VA has a fourth mission of also supporting our local communities in which we are based. And so the VA was, as quickly as possible, trying to get everybody on board in that mindset that that was a potential concern and possibility down the road. One of the challenges, of course, for all of us is that we didn't know much about COVID. We didn't have a lot of information about how patients presented. And so we were going as quickly as possible over every bit of research that was out there, incorporating it into our plans and trying to be as prepared as possible. That included also conducting inventories of equipment and supplies to make sure that we had everything available that we anticipated would be needed, such as protective equipment. And we started reducing access. So we limited people coming in to visit family members in the VA. And we also limited people coming in for appointments. So we started slowing down those appointments that might be useful but not critical. While we don't do voluntary surgeries or anything here, certain appointments can be reduced or at least can be delayed. And so we started doing that in February. And when I say we, I want to make it clear, I wasn't yet a part of the planning and the response at this point. They had a team a coronavirus rapid response team that was already formed, and they were anticipating an incoming emergency manager at this point. And so they started making SOPs, or standard operating procedures, and they started planning for surge capacity. And what that means is they were anticipating an influx of patients, or patients that required more care than we typically give. Surge capacity can refer not just to quantities of patients, but also to the amount of resources and time and staff that are needed to respond. Next slide, please. So come into March, we started initiating screening at the doors of the entry to the facility. We reduced how many doors people were allowed to come in, but we also discovered that the incoming emergency manager was no longer coming. And so this was a big concern, because they knew at this point, the VA knew that this was definitely something that they needed to have at every site. And the leadership at VA Bedford started considering their options. They learned through one of my other colleagues that I had a background in emergency management. And so they asked me if I'd be willing to be detailed, which of course I said yes. I think, like anyone who's ever responded to an emergency or served in the military, you really, when given an opportunity to be able to use your lessons learned and your best practices and your experience, you of course want that opportunity. And as I mentioned before, my experiences responding to the USS Cole, and by being a part of the planning in Northern New Jersey, and then with the National Emergency Response and Rescue Training Center, made me realize how lucky I was to have those experiences and that background. And I really wanted to share it. I wanted to put it to use. I didn't want to just be sitting on the sidelines. So I was really lucky to be brought in to be an emergency manager. And I'll make it clear, the emergency manager is not in charge of the response. That's really the leadership is always in charge. They don't, stop being in charge during an emergency, but really an emergency manager helps manage or coordinate the response, just to help make it as efficient as possible, because everything is ramped up. So that was about March 13th when I got detailed. And a few days later, we had our initial official incident command team formed. And that follows the incident command system program that was designed actually years ago out in California, with all their experiences with wildfires and with mudslides. The state of California's fire services and emergency managers developed this incident command system really based on what we use in the military. So it's very familiar when I learned it years ago when I started working at the National Emergency Response and Rescue Training Center. So incident command basically uses the SHOP program, where you've got people in charge of supply, people in charge of operations and planning, and then of course your commanders, people in charge of information. And it's not too much of a departure from what we do normally, except there are certain things that you do during an emergency that you wouldn't typically do in a healthcare organization. And in California, they also modified incident command system to different organizations so that there is a hospital incident command system, or HICS, and we started implementing that. Although we were only doing it at a lower level, because at this point we didn't yet have any patients, and we were really just still in the preparatory phase. But 2 days later, the Office of the Inspector General showed up to inspect our preparations. Not a total shock. This is what the OIG does. They're designed to make sure the VA is doing things properly and managing resources and processes in the most efficient way possible. But it was one of those things where you thought, really, we're just trying to get ready. But we went ahead and we went through that inspection, and that also allowed the VA to keep tabs on how well all the VAs were preparing and how well they were outfitted to be able to respond based on the information we knew at that point. Then on March 24th, we started drive-through screening. And when I mean screening, I mean that everybody coming up to the doors was asked multiple questions. Many of you are very familiar with these, asking if people had had contact with anyone who had COVID, asking if people had any symptoms, if they traveled. But what we realized is it was slowing down the process at the front doors for our staff coming in. And already by end of March, many of us were eating drive-through so often because grocery stores were reducing their hours, that this came to me one day as I was driving in, thinking there's got to be an easier way to do our screening. Why don't we try drive-through? So we actually established drive-through screening at our front doors, and that greatly reduced the amount of time that it took for staff to come in to get to work. So we were innovating from the very beginning. And what was really nice is that it was a lot of collaborative brainstorming and innovation every step of the way. And in that way, we were definitely on the front lines because many of these things had never been done before. Next slide, please. So we also were testing whenever anybody had symptoms, but also and when I mean everybody, I mean both staff and patients, both outpatients and inpatients. We were screening our staff and our inpatients every day for any symptoms whatsoever. So we weren't just conducting screening when people walked through the door. We were very diligent about doing screening at the unit level, and supervisors were asking their staff every day to ensure that they weren't having any symptoms. And that's what allowed us to prompt people to get COVID tests taken, because in March, we still were only following testing guidelines. Testing guidelines told us if somebody had symptoms, that's when you tested. We weren't doing any testing just regularly, just in case. So this was testing based on symptoms, or if someone had a confirmed contact with someone who was COVID positive. So March 26th, we had our first outpatient who tested positive, and March 27th, we had our first employee test positive. And I can remember when we first learned about this, it was really kind of not a shock, but almost like, okay, here we go. You knew that the game had basically started, that we were really going to be experiencing more of this, and that we were going to have to learn a lot of this as we went, because at this stage, there was still a lot of information that we didn't have. But March 30th, we already had our first congressional complaint because someone had complained to Congress that they were concerned we didn't have enough protective equipment. Again, remember, we still had a lot of questions about what protective equipment was needed. Our staff were already being very cautious and employing infection control guidelines that, such as wearing masks if they were talking to patients that they thought might be COVID positive. But there was a lot of concern across the board and a lot of questions. And so someone made a complaint to their congressman. This did happen a few more times where people felt like they weren't getting answers, and they felt very unsure and unclear about whether or not we were doing the right thing. And congressional complaints, whether you're in the military or in a federal organization, do require an immediate response. It's very thorough and comprehensive. They're not all bad, because it does make you make sure that not only are you doing the right thing, but you're getting the information out. But it definitely was one of those things where it does cause a little bit of a speed bump in your preparations because it takes so much time. Next slide, please. So April, I mentioned before, we were already working on our surge capacity. And one of the plans for surge capacity was to have a unit that was designated for COVID patients, meaning that only people with COVID would be on those units so that there was no contamination of other people. And the staff who worked on that unit would only work there. So we were already preparing that unit when we got word that the Chelsea Soldiers Home needed help. And the way we found out that word was that the VA was working with the states, and the states would come to the federal government and ask for assistance, and to include to the VA to help out with taking patients who required care that they did not have the capacity to do so. So we actually were finishing up our positive unit, and then found out that the Chelsea Soldiers Home needed assistance, and that the VA wanted us to support them on that. We wanted to support them on that. So we certainly accepted that mission very, very enthusiastically. But we can't do so until we get the go ahead from the VA, which we of course did, because the VA was really embracing its fourth mission. And so our engineering department, our environmental management department, our nursing staff, and our provider staff, nutrition and dietary, and so many others worked extremely hard to get our unit absolutely up and running in time to receive these patients. It required moving patients from an area to another area, prepping that area for them, and then ensuring that we had all these open areas prepared in this other unit, this new unit, this COVID unit for the patients coming in. We also had to set up negative air. That helps prevent the air from flowing into other areas of the facility. And our engineering department actually did just-in-time construction. It was quite incredible, and people put in a huge amount of effort and dedicated time to prepare this unit. It was really incredible. And those soldiers then, or the veterans then came to Bedford. The reason some of them came to us is, and some went to Boston, is that those who needed a high level of care, such as respirators, would go to Boston. We received those veterans who did not need respirators, and those who maybe were, needing palliative care. That's what we do at Bedford. It's one of our specialties, being able to provide palliative care that shows respect and honor to a veteran and their life. So 10 veterans came from Chelsea Soldiers Home initially. We had a few more show up later. I shouldn't say show up, brought to Bedford later. And we were able to provide them care. And we all felt very happy that we were able to assist our community partners. And it's become really kind of an amazing experience to see all of those staff so dedicated to helping out those veterans, still here today, how well many of those veterans are doing because of the care that they provided. So April 3rd, our director decided that all Bedford staff would be required to wear face masks. This was months before the CDC and the rest of the VA went to face masks, but she's very proactive. Our director is extremely proactive and felt it necessary to protect our staff as much as she possibly could with the supplies that we had available, knowing that those staff that were on the front lines really needed a higher level of protective equipment. We reserved masks like N95s and gowns and gloves for those staff who were in the most likely position of either being exposed or to possibly expose other veterans. And we also made sure then that all staff had regular face masks available to them, the ones that are the regular surgical masks that most of us wear. So we had those issued at the screening stations or to sections, and staff started wearing those whenever they were around the facility. April 5th, we actually deployed 2 of our nurses to help out in an ER and an ICU in New York City. This was at a time when the VA in New York City and many other hospitals were really overrun with COVID patients and needed assistance. So not only were we preparing to help out our own community, but we also were then helping out other locations like New York. Next slide. So just a few days later, we had 7 inpatients test positive. They had screened positive when we asked them the questions or checked for symptoms. And so we were anticipating that we might have some positive inpatients. So because we had that COVID unit up and running, we were able to move them there. But I also recommended then to our director and infection control, and I recommended this together, that since we did have that many on one unit, we really needed to do point prevalence testing. So what that requires is that you do a large number of testing for anybody who might have been in contact with those patients. And when we did that, we found we actually had 10 COVID positive staff members and 17 veterans who were COVID positive in addition to those first 7. So that meant that things had really ramped up again for us. We did a restructure of our incident command a couple of days later that brought in even more subject matter experts and ensured that we had additional people to conduct planning. We were really implementing hospital incident command at this point so that we had a very organized way of collaborating and conducting detailed planning. We used something called the Planning P. That's a concept from FEMA that helps make sure that you're providing enough time in your operational period for planning and response, and then following up on results from that planning and response so that you're ready for the next day. And so we implemented that included a briefing to our director, and then she could give us additional guidance, and we could make sure that she was aware of what was going on from the last operational period. And then we would have tactics meetings where we would work very closely together, conducting planning and preparing for operations. And that Planning P allows you more time to respond and less time bogged down in meetings. So it worked out really well. Next slide, please. So just a few days later, after that new change in our incident command, we had 2 more units established for COVID patients because we were seeing more people, more staff, and more patients showing symptoms. We also submitted a request to our region to ask for backup staff to help out because we knew that we needed additional staff, especially nurses, to help out with our patients. And we got incredible support from our region. It's something we talk about all the time, about how great it is to be part of this region. The New England region of the VA is incredibly collaborative and supportive. We cross-leveled not just staff, but also equipment and materials and protective equipment included, so that every unit that we had sufficient supplies and resources available to them. That's really due in part to not just our own preparations, but largely to the collaborative response in our region. We conducted a second point prevalence testing on April 16th, and that went out to 8 units. We have 11 residential units here. And so this was now 8 units that we were looking at based on what we were seeing in our screening questions of our patients and our staff. We also felt it really important that we communicated not just to our staff, but also with the families. The director wanted to make sure that we were reaching out to the community living center families. These are the spouses, and the children of our veterans who live at the Bedford VA regularly. She wanted to make sure that we were really talking directly to them and letting them know what was going on and how we were responding. And we did the same thing with our staff. And it really helped make sure that people had information available. They could ask questions and they knew that we were reaching out to let them know what was going on. We had a hotline established for the families as well. And unfortunately, we actually had 2 veterans die of COVID on April 16th. And again, that was such a surprise for so many of us because we really, even though we knew it was possible based on what we were seeing around the rest of the country, it was still so heartbreaking to lose one of our own and one of the Chelsea Soldiers veterans, because we really all feel like our veterans are our family. So this was a really, really tough day. Next slide. And as you can see throughout the month of April, our numbers continue to increase, both our inpatients and our employees. And what we know now looking back is that many of these people probably were positive or were becoming positive at the beginning of April, even the end of March. But testing didn't allow us to know this information until really mid-April because we were really just learning about how COVID worked. So we did a 3rd point prevalence testing, this time of 4 units. We established another COVID positive unit to help reduce the spread. And we also started recognizing the stress that this was putting not just our families and our veterans under, but also our staff. As I mentioned, it was a really hard day when we lost one of our own veterans and one of the Chelsea Soldiers Home veterans. It's very difficult every time we had a positive patient. Our staff were really, it was gut-wrenching for them because some of them have known our veterans for more than 10 years. So these are family members for them, and learning that they were ill and that, many of our veterans have very complex health conditions. It was so difficult for our staff to feel like they couldn't do more to really help our veterans out. So we did this survey to try to gather enough information to understand how to support our staff and ensure that they were resilient and that they didn't become burned out, because we knew that this was going to take a while for us to get through, and we wanted to come through it together as a team. So our numbers continued to rise throughout the end of April, and then we started doing testing whether or not someone had symptoms. It's called baseline testing or surveillance testing. So we were doing this on a regular basis, testing anyone who worked on the CLCs. So that wasn't just the staff who were on the units all the time, but people who maybe visited the CLCs to deliver things such as food or laundry. And also additional staff like leadership who might go there to visit veterans and visit staff. Everybody was getting tested on a regular basis so that we could catch it before symptoms even became visible, because we were learning at this stage that the symptoms show up usually after someone has already been infectious. And that's not unusual with infectious diseases, but we didn't know that yet about COVID. Next slide, please. So going into May, this was the first time that there was really official guidance saying to all staff members in the VA that you need to wear face masks. And I just, again, want to commend our leadership for being so proactive in putting us in masks beforehand, because I think that they really avoided a much worse situation. It was due to mask wearing as well as infection control and the engineering and facility protocols that we put into place. That we were able to slow down the spread. But I really, again, am just so grateful to our leadership for being so proactive in this. We still were seeing a rise in some of our inpatient veterans testing positive, as well as our employees. And unfortunately, at this stage, we were seeing more deaths. We had veterans who were being treated at other facilities. We also refer to that as absent sick in hospital, because we're not specifically a hospital, we're a medical center. Some of our veterans had to go out to other facilities to receive a higher level of care, such as a respirator. And we had 7 veterans at this stage out at other hospitals. And unfortunately, we had 8 inpatients die at this point. And then 8 veterans died at other locations. These would be veterans who'd gone to other facilities for more care. In addition, we had 2 home-based veterans who were receiving primary care in their homes pass away as well. And as we saw these numbers rise, and as we shared them with our CLC families and with our staff, this was an incredibly hard time for our leadership, knowing that, it wasn't yet slowing down, but we felt it really important to share this information and be as transparent as possible with everybody so that they knew what was going on. So May 3rd, we were still helping out other locations. We actually sent an air conditioning mechanic to help out in New Jersey, because New Jersey was hit even harder than we were at this stage. So he went down there for 2 weeks to help out with them and ensure that their negative air and other ventilation was helping with the response rather than contributing to the problem. So we're really grateful to our staff who are able to go out to other locations to help out. Next slide, please. So we designated a quarantine unit because we started seeing patients recovering, and we wanted to put people into a location where they were no longer positive with symptoms, but they weren't yet ready to go back to their units. But we also needed a quarantine unit for those veterans who were going out for care, such as dialysis. If they went out for dialysis, we wanted a quarantine area so that they could be kept there while we monitored them for any potential symptoms, because if we couldn't control them by having them in one location, it was necessary for us to have quarantine just in case they got exposed elsewhere, because we didn't want them to bring it back to a unit. So we were really careful about observing them once they returned back from care from another facility. Some of our veterans who are on dialysis a couple of days a week were on a quarantine unit for months, and it was incredibly hard for them and for their families. But it was unfortunately a necessary part of our response. But truly, it took a sacrifice by the veterans and the families for them to do that. So I know that the staff felt very acutely upset on behalf of those veterans that they had to do that, but it was a necessary part of the process to ensure that there wasn't spread. We had still 4 patients being treated at other facilities. We had 26 outpatients at this point who were positive that we were aware of because they've been tested here or had reported to us that they were positive. We had 92 employees who were COVID positive. And so we were really needing a lot of backup from other locations. We also at this stage didn't know how to measure when someone was fully recovered from COVID. So we were very cautious before we allowed people to come back to work on the units because we wanted to make sure that there was no chance of spread. And as you can see from the numbers there, we still had the total of 8 patients who had died in-house, 8 at other facilities, and 2 at their homes. Next slide. In May, later in May on the 7th, we had an increase in positive outpatients and employees, but it seemed to be rising at a lower rate. But we did have an increase in deaths inpatient. Some of these, again, it was so difficult because we really thought a number of these veterans were going to pull through. And so it was incredibly hard for us to see them not make it just when we thought they were about to turn the corner. This was a time when I remember our nurse exec talking about going down to the units to see her nurses and hearing some of her staff in the break rooms or in other areas so heartbroken over the loss of their veterans that they were crying and just crying together because or by themselves, because it was just so painful for them to lose their veterans. So this was a really, really tough time, especially for our nurses and nursing assistants, psychologists and social workers and physicians who work on the units. I remember talking to our nurse practitioners who work on our CLC units just about how hard it was for them because they get to know the veterans personally and they get to know the families. So this truly was a really incredibly difficult time. Next slide. So as May went on, we had 4 more patients pass away. And, but we were seeing at that time that our numbers of inpatient veterans and who were positive with COVID and our employees who were positive with COVID was going down. So we're really happy about that. We were also at this stage given better guidance about how to assess whether someone had recovered from COVID. It was a combination of using symptoms as well as time. So not just someone was being tested and was still positive for months, because what we know now with COVID is that someone can test positive and then 6 months later still test positive, but they aren't infectious and they don't have any symptoms. And so what we wanted to prevent was having people on a COVID unit in case there was any risk of reinfection, if they were not infected. And we also wanted to get them back to their rooms and to their material possessions. Because it was, we were taking them out of their usual home and having to put them into a COVID unit, which was much more sparse. May 12th, we lost our first employee. This was actually a veteran who was also an employee who worked in our fiscal department. He was well loved, and that department, really had a very, very challenging time. A number of them had become COVID positive, and the loss of this employee was a real shock to all of us. But we were happy that 2 days later we were able to return the last Chelsea Soldiers Home veteran to their home. So a number of those veterans recovered and went home by mid-May. So while it had been a couple months almost that they had been with us, and we'd grown pretty attached to many of them, it was so joyful for us to be able to see them be picked up by Chelsea Soldiers Home and be able to go home. Next slide. Our numbers continued through May to go lower among both our employees and our veterans. And we started realizing that now we were in an incident stabilization phase. This is when you see your numbers either stay neutral and not rise, or they start going down. And so we did see that, while we did lose a few more veterans, we definitely saw the pace slow down, and we were really happy about that. But as you'll see, May 26th, the end of May was a very difficult time because we lost more veterans. And I can remember speaking to the CLC families and actually not being able to talk about these numbers because it took me a second to be able to even process the words that I was saying, letting them know about the loss of so many of our veterans. Next slide. So June 1st is when we had finally enough information from the research to develop a discontinuation of transmission-based precautions. I mentioned earlier that we were developing our own, that we were learning guidance from the VA and from research and from the CLC about how long to keep someone in quarantine or how long to keep someone in a COVID positive unit before we could return them to their own units. And luckily, by June 1st, we already had enough information to establish a standard procedure and policy that we could follow that was blessed off by the VISN-1 clinical work group, and ensured that we kept patients safe for as long as possible, but not prevent them from going back to their homes longer than we needed to. We continued our surveillance testing. We were doing this really every week or every other week, depending on what section people were in. And at this stage, we only had 7 positive employees and 26 positive inpatient veterans. Next slide. So we felt like we were in recovery just a day later when we saw our numbers continue going down and we were able to start talking about reopening. Other locations in the VA that had not had such an experience with a COVID outbreak were able to reopen their outpatient clinics and reopen access to different programs that were, maybe educational programs for veterans, or benefit programs for veterans. We still had to take it a little bit slower because we were still responding to the COVID outbreak. But as you can see, our numbers were a lot lower. We still had every precaution in place with infection control. We still were all wearing masks, but we could start planning for our clinics opening again and allowing outpatients to come to our primary care and urgent care, or at least to do telehealth on a more frequent basis. We had a very low number of positive inpatient veterans and employees, and we started expanding services on June 8th. And looking back, so much had happened in those really April, May, those 2 months. It's shocking to think that it was just really 2 months and 2 weeks when we were able to open our clinics again. It really felt like 6 or 7 months had gone on. But our mental health outpatient clinics, our audiology, and our inpatient podiatry, all were able to start expanding their services. They did it in an innovative fashion. A lot of things were moved to curbside or to telehealth. But we also ensured that we provided veterans a number of different ways to access us. And depending on their needs, many of those were face-to-face. But we really tailored it to the individual veteran, but to ensure the best in COVID precautions. Next slide. You can see our numbers are really, really low here by mid-June. And we were able to open neurology Botox, which is for migraines, and outpatient podiatry, expanding even further. We had no positive inpatients after June 16th. That was where we considered our wave was really, was finishing up, as we only had 3 positive employees. And we are able to further expand services to primary care and our community-based outpatient clinics, to dental, optometry, and nutrition, the week of the 22nd, and then the 26th, women's health expanded services. You can see we had a little bit of a rise in positive employees because, of course, our employees don't remain here. They do go out into the community, and there still was quite a bit of community spread going on. But that's why it was so important that we were keeping up with testing and screening to make sure we caught any likelihood that somebody had COVID-19. Next slide. So July 1st, we had a total of only 2 employees who were unable to work, but our number of employees who had returned to work after having COVID was 118 at that stage. So our first wave, we had 120 employees be COVID positive, and our last employee positive was July 8th, and he or she recovered on July 20th. It's about a 14-day window when you can be considered recovered if you have no symptoms and sufficient time has passed. So we were really, really happy that we'd reached this stage, but definitely glad for a bit of a break from the challenges we'd experienced. Next slide. So in the last several months, our focus has been on continuing to reopen, but also to maintain our vigilance about weekly testing, about screening, maintaining our infection control procedures, but we haven't had to have COVID positive units at the same level as we did before. We have had some small numbers of positive staff, but we've also had a few veterans who've been put on observation because they've been exposed to those staff, but we've been very lucky to be able to be back to 0 again. And even more lucky that the VA was, again, very proactive and was able to receive a large supply of vaccinations. We at VA Bedford are incredibly fortunate that we also conduct a lot of research here, and that research required a certain type of refrigeration unit that meets the standards that's required for the Pfizer vaccine. So we were one of the first 5 sites in the United States, in the VA, to receive the Pfizer vaccine. And we actually started our vaccinations of both staff and veterans at the end of December. Next slide. And those staff were those who are on the front line. So again, our nurses, our nursing assistants, our providers, but also our environmental management staff. But more importantly, our veterans who live in long-term care were the first group to get the vaccine. And the first person in the US in the VA to get a vaccine was at the VA in Bedford. That is Margaret Klessens. Many of you know her if you volunteer at Bedford. She's a 96-year-old World War II veteran. And I actually had the opportunity to be there when she received her vaccine, and she was as spicy as normal. She was real, excited excited to get the vaccine, but just sort of calm about it all. And the rest of us were almost in tears because we were so relieved to have the vaccine and be able to provide it to our veterans. And so grateful that we have such an incredible team conducting the vaccination operations. The woman providing the vaccine or administering the vaccine to Margaret there is Sandra Getchell. She's an incredible nurse here at Bedford. She and this amazing team of staff are conducting vaccines in our theater and also in the community now. But we established a vaccine operation in our theater in Building 78 and started out, our first priority was our frontline staff and our veterans who live in the CLCs. And then we've expanded it now. And now we're at the stage where all staff can get the vaccine and our veterans in the community can receive the vaccine as well. And as Gresh mentioned, the number to call is the 4000 number. It was published, I believe, in the chat as well. While we're conducting vaccinations at VA Bedford, if you have friends or family who are veterans who live out in the community, they can also inquire about receiving the vaccine in Gloucester, Lynn, and Haverhill in the next few months by calling that same phone number. So it's 781-687-4000. And they can, veterans can ask about getting vaccinated, find out if they're within the priority groups, and then get registered for the vaccine. A number of you I know in the LVA have already received your vaccine. I've received my vaccine as well. And I could not be more grateful to have that opportunity to the VA. I'm completely indebted for this opportunity to be able to get the vaccine and to be a part of this response that we had. I can't say enough about the staff here at the VA in Bedford. The leadership, the management, the supervisors, and the frontline staff are so dedicated to our veterans. Some of our staff were living in their garages or their cars because they were afraid of exposing their family members, but still wanted to come to work every day. And our staff worked countless hours just had all of their heart and soul into providing care to our veterans and stopping this really during a time when we did not know exactly what we were facing. People, whether they were our nurses or our chaplains, were willing to put on their equipment and go in and take care of our patients without hesitation. And to be able to support their efforts as the acting emergency manager was a gift. I'm incredibly grateful to be a part of the response. I can tell you that this is just an amazing team here and truly on the front line of a crisis at the national level and just fully dedicated to taking care of our veterans and in our community. We conducted vaccinations this weekend in Gloucester. And in fact, we vaccinated over 400 people over the weekend, 300 plus on Saturday, 150 plus on Sunday. Due to the weather, it was reduced, obviously. But the clinics out in the community will continue and we'll go back to do the second doses in Gloucester at the end of this month. And we'll be in Lynn on the 20th of this month. So if you have friends who live in the area, please let them know. And we'll be doing a lot more publishing about it. You can find out more information on our website, which is bedford.va.gov. On the main page, you can go to a box that has information about COVID vaccine and click on that to get the latest information. Next slide. So I'm very happy to take any of your questions or tell you more about our response. And I just want to thank all of you for your attention today and for the time to be a part of LVA and to share with you the amazing response that VA Bedford put in. And I'm very grateful for your time. Thanks so much.
Well, okay. Sarah, thank you for that thorough story. We appreciate it so much. And in addition to the information you gave us about the vaccines, the telephone number that Gresh has provided in the chat line is there for anyone who wishes to make a phone call. So Thank you to both of you. Okay, time for questions, folks. I have one of my own, but I'll wait for a minute. So our first question is from Gresh. Sarah. When will volunteers, Gresh is a hospice volunteer, as I recall.
Yes.
When will volunteers be welcomed back to Bedford?
Yeah, that's something that all of us miss so much. Our volunteers do so much here at Bedford. My library team is just one small part of that. Gresh has been a big part of the response as well. And we're not yet at the stage where we're allowing volunteers to go onto the units, but one of the ways that people can volunteer at Bedford is in the ambassador program. And those people are actually closely aligned with the response through the vaccination clinic. My friend Sarah Duncan runs the patient experience office, and she's our chief of that. And she has the ambassador program under her. But if people are interested, they can contact me and I'll connect you, or they can contact voluntary services and they'll connect you to Sarah Duncan. But the ambassadors are the individuals who help people who have questions when they come in the front door. And they also will help people get to the vaccine clinic because the theater is away from the main entrance. And people who help out in that respect are able to get the vaccine if they haven't already. So that would be veterans who are in the ambassador program. So it is reserved for veterans typically, but also there's volunteers who are non-veterans who are in that program. And so that's an opportunity now. We don't yet have a timeline for when we'll allow volunteers back onto the units completely, but I do know that it's under consideration by our leadership because they just want to be very cautious. Their first concern is making sure that the families can come onto the units. They really want families to be able to come see their loved ones. That's really a big priority for us. What people have had to do in the last several months is visit outside in a booth or, really over FaceTime, basically over iPads or phones. So right now that's our first priority is reopening the CLCs to families. And then I know that the volunteers will be soon after that.
That's a very good volunteer opportunity, being an ambassador. Thank you very much for mentioning that. And that's something that lots of people could do. So that's good. Glad to know that. Thank you. As a reminder, folks, if you have a question and you just want to type it in and have us ask it for you, just click on the Q&A button and type your question. If you would like to ask your question directly or offer a comment, then click the raise hand icon and we will call on you and you can speak, okay? In the meantime, let me ask a question for Sarah. Since I know part of your job is to focus on challenges ahead, look ahead and do strategic planning. One of the offshoots of this that is entirely out of your control, but it's happening. It's happening to all residents of long-term care facilities, not just here with veterans, is that by being confined to their rooms for a year, the veterans are suffering from all kinds of situations. You know, they have their meals brought to them. They don't go to group dining anymore. They have their social interaction is completely limited. I mean, they do have the staff come in occasionally. Their physical conditions are deteriorating because they don't walk around. They don't get exercise. And they're lonely and they're isolated, and maybe their psychological status is deteriorating through no fault of anybody's. So when this is all over and when this is behind us, you probably are already planning on how to try to get everybody back in shape psychologically and physically. So what are you thinking about along those lines?
So again, I have to say we're already doing it. And when I say we, I'm, saying, the staff here, but from the very beginning, the nurse managers, the rehab specialists, the physical therapists, the occupational therapists, and the providers all recognized the concerns that they had about someone being confined without exercise, whether they had COVID or whether or not they were just confined to their units. So from the very beginning, they actually started programming that allowed for exercise and allowed for interaction and did as much as possible to attend to both physical and mental health. And that's why, again, I can't say enough about how amazing the staff are here, because none of this had happened before. And yet they were anticipating needs that were based on their experience, based on their knowledge, based on their skills, but also based on how much they care about these veterans. And so they really considered every aspect. For veterans who got COVID and were ill, we knew that they often had a very long road to recovery. So there were restorative care services that were put into place for them on recovery units. So we actually had recovery units for them. So it was a step down from being in isolation with COVID. They went to a recovery unit where they went through that physical training to help improve their daily life. And we also had similar programs for people who were on non-COVID units, people who did not have COVID. They put into place programs to ensure that people got exercise, whether it was just walking down the hall. When the weather has been nice, we've taken people outside, and we had staff members like our nursing assistants or nurses or others take people on walks outside to get them some fresh air, because just being inside all the time isn't healthy. And we knew that. We established areas outside the facility that were closed off from other people, but still allowed people to go onto a patio and have some fresh air and be outside, spaced out enough from other people that they weren't within 6 feet, but still allowed them to get some fresh air and some movement outside. Our physical therapists and recreation therapists went onto the units as quickly as they could after we knew things were safe enough to do that, to provide programming, but really individualized, because as you said, we couldn't do group stuff. But the veterans are able to do some activity outside of their rooms. They're not stuck in their rooms all the time, but they don't have free reign throughout the whole facility yet, because we do want to make sure that they're not exposed and don't inadvertently bring it back to the unit. So we are still taking precautions, and we're very careful with our planning about that. But that's why our nursing staff, one of our nursing leaders, Kelly Sandin, from the very beginning started programming with her resource nurses and her nurse managers, because all of them had a lot of ideas that they wanted to, ensure they were providing different outlets to veterans, whether it was a parade where the families could come by and see their loved ones. We had a community parade where first responders from throughout the Boston area came by Bedford, and we had our veterans either outside or at the window so they could see the support that they had. I had iPads in the library that I gave out to all the units so that they could have FaceTime with family members very early on. Our nurse executive made the decision before we really had complete guidance on this. She did an assessment along with her providers about the safety for loved ones. And so when someone was at end of life, she and our leadership agreed that we needed to allow people to come in to be with their loved one at the end of life, because we didn't want to prevent that from being a time that families could be together. And so we really, a lot of our staff were just very innovative, but very mindfully innovative and really anticipating those needs. That's not to say that, they've had exactly back to normal yet. We're not there yet, but we also took what had been our old smoke shacks and had those renovated. ServPro actually donated their time and labor and materials and cleaned those out for us. And we created these outside, essentially like a greenhouse where people can go and be outside, even if it's cold outside. They can see outside and have some outside of the unit time. So there's a lot of different programs, and I can't speak to all of them. It would take a long time to do that, but there's so many programs that our patient care services have put into place just for that need, knowing that that's a need. And in fact, the VA designated psychologists who are their role in our COVID-19 response is to anticipate the concerns about isolation and withdrawal that happen to veterans who are in long-term care or in inpatient units with COVID for a long time. So we have a number of staff from different disciplines who are very focused on this issue and ensuring that our programs and our services address them.
Sarah, that is fabulous. I had absolutely no idea that so much was going on, and I'm very
it's an incredible team here, truly.
That a lot of people are very, very happy to hear all those wonderful things that are going on. That's great. Carl has another vaccination question. I think there's a lot of interest in vaccinations. So he wants
I'm glad to hear that. That's great.
If you are a veteran, but you're not enrolled or you're not eligible for VA healthcare, are you still able to get a vaccination through the VA?
I always tell people call to find out to be sure, because what we had in Gloucester this weekend were a couple people in that very situation show up and find out that they actually were eligible. They weren't eligible for all services. They weren't 100%, like I'm not 100%, but they actually were eligible for some services. And so I always recommend call, double check on your eligibility for services to make sure, because we really want to make sure as many veterans as possible are able to receive the vaccine. So don't hesitate, call the number, double check, make sure. For a couple of years, I wasn't eligible for VA care, and then I was. And so sometimes the policies and eligibility protocols change, or the parameters change. And so it's worth a phone call at the very least to make sure.
And we have, for everybody's information, we have reposted on the chat line the website and the telephone number to call.
So the website is actually bedford.va.gov, just in case.
Ooh,
But you can also
Bedford
Google, yeah, you can also
VA.
Google Bedford VA Hospital
.gov.
and you'll find it. So yeah,
Okay, I bet Christine will take care of that right away.
yeah, she's great.
Okay. We have two, not questions, but just very nice comments for you, Sarah, and I do want to read them. One is from Edlo Turco.
Oh yes, hi.
Yes, kudos to Sarah. Very well done and thankful. I am thankful to have you. I am thankful to be a part of the Bedford VA. Ed is an active
Yes, he
client
is.
of
Yes,
Bedford
yeah.
VA at the moment. So he wanted to be sure and tell you and our audience that. And Erin McCormick says, thank you for this moving and informative program. Thank you to Sarah for all you've done for the Bedford VA.
So I can't emphasize enough. I absolutely love Erin, but I have to emphasize, truly, I was just a very, very small part of it. I mean, every aspect of this was truly a team effort, but it was because people were so thoughtful and caring about their veterans always, that they, you know, when it came time to respond, they were fueled by that. And even in the midst of loss, they felt it important to commemorate and honor our veterans. And so we've even had a memorial ceremony that they made virtual for families who could not attend in person. We've had so many different programs that are designed to help out our veterans and our staff and our patients and their families. It's just incredible. And truly, I'm honestly just a teeny part of that. But I am glad to have the chance to talk a little bit about everything that everyone's done.
Erin also has a question, but before her, Patricia Hilsinger wanted to, she has her hand raised. Pardon me. So Patricia, you would like to speak. You go right ahead.
This is really less important than all these other questions. Maybe you
No,
could put me at
every
the end.
question is important.
No, I just, last year I went to one of the Cary Library programs on veterans, and the director of Starbucks said, we really need your magazines. Come and bring them to Starbucks and I'll bring them to Bedford. And I, for years, have brought wall calendars and note cards that
Yes.
that organizations I donate give to me. So my question basically was, at what point are they going to start accepting? This year they said we don't accept anything because of COVID.
Yeah, that's
Actually,
that's a great question.
Pat Costello is here today. The only thing I think that they accept now because of the situation are calendars. And because it's February, I don't know if Pat Costello is still accepting calendars. I'll ask her if she is.
Well, I only mentioned it. I mentioned it so that others on the line would be aware that this is something they can do too. That might help if they can.
We have to suspend magazines and note cards, don't we, Sarah, for the time being?
Yeah, so I'll add to that. I want to highlight just how grateful I am for all of your support. Patricia, you and so many members of the LVA have done so much for the library, and in turn, so much for our veterans, because we delivered those materials throughout COVID. I delivered them myself. More materials came in because of my volunteers. You know, Aaron and Frank and Jim and Tom and Dick all brought things in. And I'm sorry, I should say Jim and Jim and Jim, because there's 3 Jims. But they all brought materials into me based on specific needs that our veterans had. And I was also able to use what was already in our library because of people like you. And we were able to deliver those to our veterans. The library is actually under construction right now. And so I'm not able to access the materials there, but the volunteers still bring me things, and I'm able to deliver them then to our recreation therapist to deliver to the units. But I'm not accepting materials right now because the library is closed due to construction. They're finally putting in a couple of things that we needed for fire prevention, because the building is one of the first ones that was built here in 1928. So it's closed for some time, but if we have a need, the best place to go is actually the website, the bedford.va.gov site. There's a link there for volunteer opportunities that will list things like a wish list of materials that are needed. So if anyone has any interest, our voluntary services is really the best point of contact to find out what those needs are. And if you are interested in donating, that's the best place to look, because they publish the most current list. And if they don't have something that you'd like to donate on their list, you can reach out to them and ask them if they'd be interested in receiving it. So again, that website is sort of the go-to for both COVID and volunteering, and that's the best place to look. But unfortunately, the library itself is not receiving things directly because it is closed at this time.
Sure. Well, do let me call on Pat Costello, because she has been our direct liaison for delivering calendars. And if we can unmute Pat, what do you have to say, Pat?
This is Pat. Can you hear me?
Yes.
Mhm.
Okay. I have been dealing with Alex Gannon, and we are still collecting calendars. And the calendars are used for patients to keep track of their appointments. And Alex will still be accepting calendars. And if anybody's got any, I just got one, a new one in the mail this last week, even though it's February. I'd be more than happy.
Calling from NRE. We work with the folks that send you out your magazine.
What was anyway? So if anybody wants to contact me, I'll be still happy to collect calendars and take them over. But
So Pat, why don't you put your contact information again on the chat line, and be sure to say panelists and audience.
Everybody, I think, is what it says. Okay.
Whatever. Yeah, that'd be great. And then
And when I get clearance from Alex,
yeah,
I will let people know that they can bring in stationery. And I kind of collect the stuff. For a while, I was giving it to Jim Ramsey to take over. So Jim has some stuff in his basement now. But
yes, I've given him boxes full. Yes.
At this point, I usually tell people don't give anything, magazines that are over 2 months old.
Exactly. Yes.
They're aging in Jim Ramsey's basement. But anyway, okay, so I will put that in here.
And thank you for the question. It's wonderful that people, we still have this spirit of.
Okay, panelists, and how do I do this? Panelists and everybody.
Okay. Now, Erin McCormick, I think you have your hand up. You want to say something? Erin, go ahead.
Okay, two short comments. The first was about the library, and you've already heard most of that, which just to say that at this point, you won't be able to see how Sarah transformed that space into such a welcoming place for the vets.
Mm-hmm.
And I know that the distribution is continuing on some level and will pick up, but you haven't seen her where that happens. She's wonderful. And the second thing, and the second thing I have to say, because she won't, and that is that I know, with a school-age child who had to be taught at, online from home, she had such a responsibility to balance what she was doing. And I know her folks helped her out, but if you want to talk about sacrifice, think about, what that takes too. I knew a lot about what happened during the COVID months, but I didn't know all the details date by date. And now I can truly appreciate what everybody went through. Thank you.
Okay.
Thanks, Erin.
So, Sarah, your close collaborator, Jim Ramsey, would like to know, getting back to your job as emergency manager,
Mhm.
what would you say if you had to come up with one experience? What was your biggest challenge as emergency manager? And then on the other side of the coin, what was your most rewarding experience?
I think, well, there are a couple different times where it was challenging. I think I'd responded to emergencies before, and I don't know, Army just does a really good job at preparing you for crises, I think. So I didn't have a hard time being emergency manager per se, but there were a couple times where I felt acutely aware that I was directing my friends into a situation that they weren't familiar with, that maybe I'd done a lot of studying on, I'd done a lot of preparing on, but it was new for them. So for example, when we did our first point prevalence testing, I said to the director, I'm going to get them started on point prevalence testing because I knew what we were seeing, and I knew based on my training, what we needed to do. But point prevalence testing, if it's never been done before, feels aggressive because all of a sudden we knew we had these positive patients, and our staff was still reeling from the idea that we had positive patients. And then I come in and I say, okay, you all need to get tested as quickly as possible. We need to do it today, and we need to test all of your staff. And people at that stage didn't even know how to do the COVID test. So we only had a small number of people who knew how to do COVID testing. So we had to do just-in-time training, and we had to do COVID testing. And then people had to just wait to find out whether or not they were COVID positive. And so that was, for me, that was hard, having to be very neutral and very directive, not rough and not mean or anything like that, but just, nope, we've got to get this done. And we need to do it now, because you could see several of my friends thinking, oh my God, we're going to find out more of our veterans have it. And oh my God, I might have it. And my family then might have been exposed. So that was one of those times where you sort of go into response mode, but I was still very acutely aware that it was my friends that I was telling, you need to be tested right now. And then when the results came back, knowing that they were positive. So having to keep that response attitude, I guess, but also still knowing that it was my friends who were the ones who were going through it. That was the hardest part, I think, because there is a difference between, being a soldier and knowing that you're going to be facing danger. And then people working in an assisted living facility, essentially, you don't anticipate that. And I was thinking about that this morning, as a matter of fact. It's, COVID is very invasive and it's very aggressive, and it was very unknown to us. So it was almost as if, for those of us who are in the military, I was in the Army, but I had friends who were in the Air Force who were stationed in England, and you wouldn't expect an enemy coming into England. It was a very sort of, it was a little bit more comfortable place to be stationed, especially in the 80s. So the 80s and 90s, imagining being stationed overseas and then all of a sudden having like an invasion come onto base. That's what it felt like, to be honest, because Bedford is, a very comfortable, loving, welcoming place. And people who work here are a wonderful group of people. And then all of a sudden they were essentially under attack. And that's not the mindset that they're normally in. And I went into Army mode, and yet these were my friends who were not Army type people. So that, I think, was the hardest part, is just sort of getting used to that, that difference. But I have to say, the people here, the staff who work here, the veterans who live here, managed so well under those circumstances, because you always wonder during a crisis how people will respond. There's the fight or flight response that we expect. Some people go into the fetal position and they can't do anything. Others, they're raring to go. I would say that across the board, because of the leadership, because the type of staff we had, while we did have tough days and staff were really hit hard, emotionally by all of this, and even physically by wearing all the gear and the stress of it all, for the most part, this was the most courageous group of people I could ever imagine working with, because they took it honestly as in stride as possible, that they had a mission, that they had a job to do, that this was not what they originally signed up to do, but they had a mission and they were really dedicated to it. And so that ended up being actually one of the most incredible parts of the job. What started out being most difficult ended up just being the most amazing. So I guess that would be my response to that. Again, I can't say enough, just how in awe I am of the staff, and they range in ages too. Some of them are quite young, and many have been also serviced in the, serving in the VA for decades, and they all demonstrated their dedication to our veterans. And as a veteran, that was just incredibly gratifying to see.
Well said. All right, I do not see that we have any lingering questions. I just want to make sure. Folks, this is your last opportunity to ask Sarah a question. Oh, did I see Arthur? Arthur's iPad, do you have a question? Were you raising your hand? Yeah,
Yeah.
go ahead, Arthur.
Yeah, my hand got tired of being held up there. The blood was running out,
Go ahead.
but I don't need a treatment. No, the slide that you, I may need a treatment for other things, but anyway,
Well, you
The,
came to the right place, Arthur.
That's right.
you showed the a slide, and you also mentioned about testing people positive early on.
Yeah.
And I was wondering, now those people, did you test them again and again? You just
Oh,
said
yeah.
you did. But why do you
Yeah.
retest if they've already tested positive? And also, those folks that did test positive, are they going to continue to be positive? And are you going to vaccinate those folks because they have antibodies already?
So these are all the questions we asked ourselves, as a matter of fact.
Okay.
So I mean, it's almost like you read our minds, but like 7 months ago or 6 months ago. So early on, the guidance we received was if somebody has symptoms or if they've had contact with someone who's COVID positive, you conduct a test. We have had a variety of tests available to us over time. You may remember early on, there was just one type of test and it took like 9-10 days to get a response, right? Or yeah. So the VA really invested heavily in testing capability. And so we have a wide range of testing capability available to us now. Initially, what we would do is we would test somebody and, monitor their symptoms, and we would then test them 14 days later to see if they were still COVID positive, because the original guidance from the CDC and from the World Health Organization and from other organizations was, okay, keep testing every, after 2 weeks, and then every few days after that to see if they're no longer negative. The problem is that the types of tests that were developed for COVID don't detect whether or not someone's infectious. They detect whether or not there's any presence of COVID-19 in the body.
Right.
So depending on which types or which brand you're using, it may be sensitive enough to detect a small viral load that does not indicate that someone was COVID and infectious. It just indicates that they had COVID. So that's why that development of new knowledge over time about how people progressed in the disease helped us determine that after a certain period of time, someone could have no symptoms. They may test COVID positive, but we're not going to keep testing them. We're going to go ahead and use a combination of time and symptoms to determine whether or not they've recovered. And so it's more technical than that, obviously. But so our providers use a variety of parameters to determine if someone's COVID positive, because the COVID tests may indicate that someone's COVID positive for 6 months. That doesn't mean they're actually infectious or that they're actually sick. It just means that there's a presence of COVID in their body.
Yeah.
And it means different things depending on different people. So some people may be sick with COVID and symptoms for a very long time, but still not be infectious to other people, but they require a specialized care. And so they might still be on a COVID unit so they can get that specialized care and be monitored really closely. Others might get COVID and be under observation for 14 days, never have symptoms, and then they're considered recovered and they're fine. But the majority of people, when they get exposed to COVID, within 4 days, whether or not they have symptoms, they're actually infectious. And that's why that continual testing to see if somebody's COVID positive is important. If someone has already been COVID positive, we don't keep testing them anymore. We don't do that anymore. After 90 days, or after a certain period of time, there may be some retesting that was conducted, but now we've vaccinated all of our veterans. And so we don't have to keep retesting them over and over again, those veterans who did not have COVID, to see whether or not they're COVID positive now. So with the vaccine, we don't have to keep retesting. We still monitor people for symptoms because the COVID vaccine is still new. There's still variants of COVID. We don't know if there might be a variant that later down the road, the vaccine doesn't prevent them from getting. The reason we vaccinated veterans who had COVID was because COVID, if you get COVID, you may or may not have sufficient antibodies to fight COVID later. And so if there's a variant of COVID that comes along and you don't have enough antibodies, you could get sick again. That's the theory, because it's essentially like almost like a different virus. And so we have vaccinated our veterans who were once COVID positive after at least 90 days. Again, I'm not a provider. I'm not our vaccine specialist. So these are just very basic descriptions of what we're doing. Much more specific information is available through our providers directly, because there are, physicians or nurse practitioners, and they can explain it further. But what we've done is we've followed guidelines from the very beginning, conducting screening for symptoms, screening for exposures, testing to make sure that people didn't have COVID, or if they did have COVID, that we put in precautions. And after a certain amount of time, they were considered recovered if they did not have symptoms. And then we continued testing until we were able to get them vaccinated. And now that they've been vaccinated, we're able to continue not having to test them, but just with our infection control precautions. And so the vaccine gives us a lot more freedom, but we're still using precautions such as masking, social distancing, and reducing the amount of people that come into the units.
That was a great question, and it resulted
very good.
in a very informative answer. So I'm very glad you asked. All right, our final question of the day comes from Mary Burnell. Would the facility accept Girl Scout cookies? Evidently, Mary has some Girl Scout cookies. If so, where should I leave them?
So again, I think, well, Pat Costello might be able to help you because she works with, with Alex Gagnon. But the best people to contact are voluntary services. They can tell you whether or not they'll do that. There are restrictions on food, accepting food, but it might be slightly different with Girl Scout cookies. I can't speak to what voluntary services will decide to do.
Mary
Yeah.
and Pat know each other, and so I'm going to put those two in touch and see if we can get some Girl Scout cookies into the hands of the veterans. Thank you for the thought, Mary.
So that, just one more thing I have to mention.
Yes,
that reminds me, again, our leaders very early on realized that it was difficult for families to get packages to their loved ones, like care packages or clothing and stuff like that. So they actually developed a service that allowed for a mail drop-off, package drop-off, so our families didn't have to spend a lot of money mailing packages in, because initially we were only doing mail because we weren't yet ready to receive those packages. But then they put into place that delivery program, and that was yet another example of the types of programs that we put into place to try to connect families to their loved ones, delivering their favorite snacks or their favorite foods or their favorite clothing or sweaters or what have you. So it just reminded me that they thought of even that, anything that they could do.
that's wonderful.
Mm-hmm.
Well, with that, I think we will conclude our program and say, Sarah, thank you so much for spending
Thank you.
time with us and giving us an inside look at what actually happens. We're all familiar. We all know about what's been happening for a year. I mean, you'd be deaf, dumb, and blind if you didn't, but we don't know the details. We did not know the details. And now we know a lot more about it. Thank you for educating us. Thank you for all you do and all your staff does, and for spending time with us. It's really been educational. We appreciate it very, very much. Okay, folks, we will see you in 4 weeks. 4 weeks to the day, as a matter of fact. And thank you so much for spending time with us. Have a good month, and we will see you again. This concludes our program. Thank you and good afternoon.